again, this medial collateral is the one that attaches to the meniscus, whereas the lateral collateral does not. And then when you examine these ligaments, when you want to test, what would you do to see if this ligament has been stretched, or to test if there's any laxity in it? What kind of force would you apply to it? Valgus or varus? Valgus. So you do this. So basically when you're testing the knee, the medial collateral ligament, you're going to stabilize here, and you're going to push this way, or you're going to move the distal part away from the midline. And then to do the lateral collateral, then you're going to do it this way. Okay? But we'll save that for OE2. And then the lateral collateral is going to attach here at the head of the fibula. Right? And then what else attaches onto the lateral, onto the fibula? What muscles are you going to attach right there? I think that is more down into here. Okay, if you feel on your fibula right there, okay, you feel these tendons going back right here. What is that? Biceps femoris. Tendinosus and membranosus are on this side. Okay, so they're going. If you follow that tendon right there, that's your fibular head right there. And then if you want to find the lateral collateral ligament, it's going to go up from the head of the fibula across the joint right here. Okay. As far as palpating these lateral collateral ligaments, whenever you're doing palpation in the knee, I don't know what I know there's a Chinese medicine name for it, but usually call it like the eyes of the knee. So you have these two kind of rounded structures right here. Okay, you find the patella, then you go down. As the patella starts to narrow, then you have the patellar tendon right here. On either side of that, you got these two like little dimple things, right? So if you go up above that, you're feeling the rounded part of the femoral condyles. You go down below it, then you're on the tibia. Okay, so if you flex and extend your knee, you feel that it's femoral condyles, they don't move. But here, the tibia is coming up. Okay? So now, you're on this spot here on the knee, okay? And then as you come, you're in like this. As you come laterally like that, you know, you feel this, you're dipped into the bone. All of a sudden, you come to the medial side, you're going to feel a structure that goes straight up and down like that. So that's going to be your medial collateral ligament. So if you're coming like this, I can feel these bones right there. Okay, now I can't really feel the differentiate between the two. I feel something going up and down right here. So that's going to be your medial collateral ligament. And then the same thing if you're coming to the other side, you get to a point where you can feel something vertical. So that's going to be your lateral collateral right there. And then if you keep coming around, then you get over here into the IT band. That you're going to feel better if you come up above the tibia, up into here. Because it's coming down. It's going all the way across like that, but you're going to feel it right here. So that's going to be this right here. Okay. So then when you're doing these tests, the test for the medial collateral ligament, you can do it in full extension, but you also want to make sure that you do it in the least pack position like this. Okay. And then same thing for the lateral collateral. And then I've got some videos I can show on these. For the cruciates, you do what's called the drawer test. The patient's on their back, their hips flexed to 45 degrees and knees at 90 degrees, and then you're pulling forward like that. So then what ligament am I testing when I do this? Anterior cruciate, posterior cruciate. So then the other thing that's what's left when we talk about the inert tissues in the knee is going to be the bursa. Right, so there's quite a few bursa in the knee. And the majority of them center around the patella. So they're going to be named based on where they are in reference to the patella. Okay? So what would be a good name to call something that's out in front of the patella? Well, pre-patellar is what you call it. Pre-patellar is out here. Okay? Then you're going to talk about suprapatellar and infrapatellar. But then those are going to be, in the infrapatellar, you're going to have one out here and one here. So this would be the superficial infrapatellar bursa, and this would be the deep infrapatellar bursa. Okay. And then you have this suprapatellar bursa. In this case, there's not a superficial and a deep, so you just call it suprapatellar. Okay, suprapatellar, prepatellar, infrapatellar, deep infrapatellar, and superficial infrapatellar. Okay. Then we've got one over here. Remember what this area of the tibia is called? Pes insurine, right? And you remember what muscles go there? One of them, sartorius. If I said this was the mnemonic, was this. Does that help?
Great.
Sartorius gracilis, that's the one from the adductor group. So there's one from the front, one from the medial side, and then one from the back side. And it's semitendinosus. Okay? So you have the pes insurine bursa here. Okay? And then what's the other significant muscle tendon structure that goes along the side here? We talked about a little bit already. Yeah, so you're going to have iliotibial band bursa right here. Because this is the part of the femur that the iliotibial band is going to get irritated against, because that's where it's going to snap against right there. Okay? It's the part that sticks out the most medial, right there. Okay? So the epicondyle. Okay? Because it actually attaches here, but as you come up here, there's nothing really there that's going to get in the way or that's going to snap on. It's going to snap on this part right here. Okay? When the knee extends like that. And it happens at the part where, like if my knee's fully flexed like this, the iliotibial band is down below that epicondyle. When you get right to about 30 degrees of knee flexion, that's when it snaps across there. And when you get all the way up to here, fully extended, it's already moved in front of that bony prominence there. It's when it gets right around this point here where it's directly over that. Okay, so that's when you get the irritation at that position. Okay, so this conditions, we're not going to get into too much. That's more what we'll go over in ONE2. But we will cover some of it because in the practical final, we're going to talk about mechanism of injury. Okay, so we'll go through the different ligaments and talk about what kind of mechanism of injury are going to injure which ones of those. Some of that we pretty much already went over as far as the collaterals. But we'll talk more about the cruciates. Okay? So what kind of injury do you get when you have compression with rotation? Meniscus. Right? So again, the cartilage and ligaments, those are all going to be inert tissues. And how do those usually get injured? What kind of trauma is it? Acute or repetitive? Acute. Okay. So to tear these ligaments, you're going to get something like this. What ligament there are they going to injure? This person's getting hit from the side like that. Yeah, they're going to go medial collateral. Okay. So the collaterals are going to get injured from impacts in the frontal plane like this. Okay. Cruciates have to do with things that go on in the sagittal plane. Okay. So the anterior cruciate limits what kind of movement of the tibia in relation to the femur? Anterior. Okay. Posterior cruciate limits what? Posterior movement. Okay. So if I fell down onto the knee like that, what ligament would get injured? Posterior. Right. And then I saw this one time when I was working as a volunteer as an athletic trainer. You see the person laying up on the table, and you look at his knee, and then it's just dropped in like that. Because when they're up like that, gravity is pulling down like that. So that knee's going to be dropped like that. If somebody has the anterior cruciate, gravity's not going to allow it to float up like that. But you can just look at somebody and you see it down like that. Doesn't look so good.